So welcome everyone. Thank you for attending. This is our second event with the new 2.0 Mississauga Halton Primary Care Network. Thank you for coming out tonight. I want to, we have a pretty packed agenda tonight, and I'm very excited about our speakers and excited about the topic as well. And of course, the topic is Ontario Health Teams and what's in it for my practice. Next slide, please. I just want to tell you briefly about our organization. We are all volunteers. We do not receive, this is our primary care network and our board. We don't receive any honoraria. We're not paid at all. We're an organization of primary care providers working together for primary care providers to inform our healthcare partners, generate ideas on improving the system, offer input, and feedback during the design phase of healthcare projects, and try to stay connected with each other, sharing information and ideas. Next slide, please. And I apologize in advance. A lot of you may have seen the beginning part of this presentation during our last one. I want to take the time out to introduce our board. We're all family doctors from diverse payment models from all over our region. So Aditi Naidu, Ali Damji, Baldeep Chera, Carolyn Malik, David Dean, Greg Vandemosler, James Ying, Mike Cates, Richard Chen, and myself. And I thought I'd introduce myself briefly as well. So as I mentioned, I'm the chair of this primary care network. I'm also a fee-for-service family doctor in Mississauga and lead physician of our comprehensive care family health group, where we lead over 130 doctors. So again, welcome. Next slide. Why is our primary care network so important, and why should every region have one? Well, primary care is the backbone, of the healthcare system. And if we look at, according to the American Academy of Family Physicians, primary care is the backbone. Utilizing primary care physicians puts an emphasis on the physician-patient relationship by shifting the focus from physician-centered care to patient-centered care. Patients with access to a regular primary care physician have lower overall healthcare costs than those without one, and healthcare outcomes improve. In areas where there are more primary care providers per person, death rates for cancer, heart disease, and stroke are lower, and people are less likely to require hospitalization. And there's lots of evidence out there that primary care, in contrast to specialty care, is associated with more equitable distribution of health in populations, a finding that holds both in national and international studies. So the work that we do is very important. And you've heard me say this again, and I'm going to keep saying it again and again, because often I feel that as family doctors, we're undervalued in our system. Healthcare transformation, that's what we're talking about tonight, is on the horizon, and we're not connected. We often work in silos. So now if we organize, we can help to support each other. I also want to give a shout out in terms of linking, and we'll put that in our chat as well, to join our primary care network. We have a Facebook page as well where you can link in as well. Next slide, please. So tonight's meeting, we had actually over 200 registered. I believe it's over 220 now. Again, we want everyone to be courteous to each other. Be nice. We're going to open up the chat, so feel free to ask questions. We have a Q&A area as well, of course, on Zoom, where you can put in your questions. In our chat, as last time, dialogue's encouraged. You can ask anything, you can vent about your day. Again, it's about supporting each other. All of our speakers are volunteers, and let me introduce, next slide, please. Actually, before I introduce the agenda, I wanted to go through these 5 questions. And this is more because we have people locally as well as from the region attending, other regions attending this seminar, this webinar. And these are the 5 questions that we asked our local OHTs. And we basically we're asking them to present these things within a minute. What are the priorities of your OHT? How will you engage primary care? How will the OHTs change a physician's life in a capitated model? How will the OHTs change a physician's life in a fee-for-service model? Or alternatively to both questions 3 and 4, how will not joining an OHT be detrimental to a physician and their patients? And the last question is, are there any plans for COVID phase 2? So if you'd like to stay for the second half, and you're not from our region, those are the questions that we're asking our panelists to answer. Of course, a lot of this is still in development. So we've also told everybody that if they don't have the answers, that's fine. We're just asking the questions. Next slide, please. So this is our agenda. I'd like to introduce our next speakers, which is from the Ministry of Health. We have Phil Graham and we have Allison Costello. So Allison Costello is a director in the Ministry of Health, currently leading the Ontario Health Team's implementation. Phil Graham has worked at the Ministry of Health for over 15 years and has held several senior management positions. He's currently the executive lead of the Ontario Health Team's division at the Ministry of Health, and he's responsible for providing leadership and oversight over the implementation and development of Ontario Health Teams, as well as home and community care modernization. So thank you to both of you for coming out and speaking to us. And I've asked them to give an overview for the next 10 to 15 minutes.
Phil's going to start on mute. There you go.
Yeah, thank you very much. Hi, good evening, everyone. It's Phil Graham here. Thanks so much for having Allison and I be part of your session this evening. I think I might just sort of kick off the first couple of slides. I think our role as part of the session is really to set the table to some extent, give you a very high-level overview of the Ontario Health Team's model and the progress that has been made to date. And hopefully set the stage for the real part of the conversation today, which is, I understand, learning a lot about what Ontario Health Teams in the region have been doing. So just moving on to the first slide, what are Ontario Health Teams? I think there's a lot of words on this slide. I'll draw your attention to the bottom part shaded in green, which is really about bringing providers together across the continuum of care to be clinically and fiscally accountable for delivering a full continuum of care to a defined population. That's a mouthful, but I think every word in that description is quite deliberate. The whole idea of clinical accountability is really to ensure that providers like the ones on the session here tonight have a strong role in leading the design and redesign of care pathways to ensure improved health outcomes for a defined patient population. I think another piece there is around fiscal accountability, and this is a piece that we do get lots of questions about, which is the idea of under a single regional governance model, including providers, patients, community members, having unified accountability for the total costs of care for that defined population within a region. And the whole idea about bringing providers together that represent the continuum of care is to bring services together in a more integrated manner, which we've been talking a lot about in the province of Ontario, and have made some progress in that regard, but still have a long way to go. And this idea of being accountable for a defined population is probably one of the more important features of the Ontario Health Team model. This idea that within a region, based on where patients are accessing care, that there is an entity, a group of people joined together through common purpose, actually have a responsibility over the outcomes and the experience of that defined patient population. So very, very important concepts here that I'm sure will get unpacked as the evening progresses. But at its core, I think that's how we would describe the Ontario Health Team model. I think one of the more important features of it provincially from our standpoint, and Allison and I have been involved in initiatives like Health Links, which is supposed to bring people together for care for complex patients. The work on the sub-region planning a few years back. I think one of the things that differentiates the Ontario Health Team model from those is government doesn't pretend to have all the answers. That I think what we're trying to do here is create an environment, put forward a model that is premised on bringing people together and really have local providers, local leaders, local communities determine the how. And I think that's full of great promise. And as Allison will describe, we are seeing pretty amazing progress in a pretty short period of time in what groups are able to come up with themselves in terms of how to bring services together, how to integrate care better, how to design care pathways in a manner that is responsive to the needs of patients and caregivers and families. And I think that's the promise, is the idea that nobody pretends to have all the answers. Government is sort of defining the what and leaving it to local leaders, local providers like yourselves to determine the how. So next slide, please. More concretely, I think when we're looking at defining the model and describing the model, we've kind of described it against 5 features. One is that, you know, it's premised on collaboration and a group of healthcare providers delivering services as one team. And again, these aren't providers within a single organization like a family health team or a fee-for-service practice or a other comprehensive care practice. This is really about a team that spans a continuum of care. The idea of patients being able to access coordination and navigation on a 24/7 basis, primarily focused on complex patients that do require a lot of different services as part of their care plan. A third feature is at maturity, publicly accessible information on how local health systems are performing. That gives a level of transparency designed not to punish, but to improve, and also helps to standardize performance in a manner that is more friendly and accessible to patients and the public in terms of how they interpret and how they understand how their system is performing, both on the provincial level as well as regionally based. A key component on that fourth bullet down is about a team of providers sharing funding and being rewarded for improvements in patient outcomes and experience. This is a very complex piece, and you know, we have learned a lot from the experience in the United States through their accountable care organizations about things like shared savings and shared risk regimes, where providers, if they're able to demonstrate improvements in experience, improvements in outcomes, while at the same time delivering care at a lower rate, the idea that providers themselves can share in some of those savings. This is somewhat of a new concept from an integrated care perspective, but certainly has been a concept thrown around over the years as it relates to compensation and other funding models. This idea of being able to reap some of the awards that are yielded through collaboration and through you know, redesigning care pathways and care more generally. And then the fifth is about more options to access health services that make sense for them. I think fundamental to how we have designed and how we will monitor the ongoing progress with Ontario Health Teams is with respect to the quadruple aim framework about better experiences, better outcomes, better value and efficiency, and better experience for the providers as well. And so we have a whole body of work underway around how we would concretely measure that performance, how we could use that to enable improvements. But that is really the guidepost that we're using, both in the design and the evaluation of how we're doing on OHTs. So I'll maybe ask Allison to walk us through in the next couple of slides, just tell you a little bit about where we've come from in terms of the progress to date, as well as some examples that we're already deriving from some of the early work that we're seeing. So thanks, Allison, over to you.
Thanks, Phil. And I'll go through the last two slides quickly, seeing a lot of questions come through the chat box. This slide just sets out kind of what our last year and a half has been to support the introduction of OHTs, starting from creating the legislative frame for OHTs, to clarifying through guidance distinct elements of what we envision OHTs being at early, middle, and future state full maturation. And then we have had a staged progressive readiness assessment process that we've supported across the province that started with self-assessment, which you will all be aware of, last spring, that we had a really tremendous response from. So a lot of interest across the system in pursuing this model. Guys, just 1 second. Thank you. So the next slide shows, you know, we're progressing along with moving. Oh, sorry, I meant the next picture along the timeline. Thank you. So following that self-assessment and full application process that followed it, 24 OHTs were announced in December last year. And a lot of teams are in the wings behind those, waiting to be supported through the process as well. And we've been supporting those groups in a number of different ways to enhance their readiness for moving forward. The most recent activity has been, or at least organized activity, and us joining this today sort of signals that we're wanting to get out more and talk more and get restarted more. So again, we're really happy for the invitation. But in March, we had communicated to all OHTs and anybody within the readiness assessment process that related to COVID, we were putting a pause on some key activities so that groups could focus locally on their COVID response. So that meant that at that time, we had been tracking to announcing more OHTs actually in June, but that intake and assessment process and other elements were put on hold. We've set out on the bottom of the slide that we are hearing from teams, and we're doing a coordinated reach out to all OHTs approved, those in development and those new self-assessments, to find out what their experience has been through COVID response. And we're hearing a lot of positive feedback indicating that the formative, just try guys, the formative partnerships that were in place, from their OHT work really allowed them to nimbly respond and have an integrated response to COVID in their local communities. So we're wanting to find out more of those great examples so that we can understand how to support more teams to really, I think we want to be able to not press pause if there is a second wave, but to make sure that we're capturing the momentum and organizing ourselves to consider both the OHT work and a COVID response in the same way. And we're working very closely with the OMA. Jim, unfortunately, has had, my children are normally really well behaved, but in the past 2 days has heard a lot of scattered noise behind us, but we're working very closely with Jim and others within the OMA to really identify strategies and barriers to engagement and involvement at the local level. And the partnership has been really productive so far, and we hope that will continue. On the next slide, and I meant slide this time, thank you. We are really noting, and we've signaled, and in the guidance document that we had set out last year, signaled and continue to really steer towards this, that integrated care systems across the world are most successful when they're based on strong clinician leadership and primary care centered models. So we're really wanting to understand how we can, you know, every community is different. Everybody is starting from a different starting point to be able to advance their OHTs. So we're really interested in hearing today and from this group and from others, what it will take to really and make the best support the best engagement across all of the clinical leadership you have across the region. On the bottom of the slide, and I won't read these out, but we're seeing some leading examples, and again, it's not a one size fits all. We know that there will be different organizations based on what the local conditions are. But there has been a lot of great activity through the OHT model that has supported better primary care and clinical organization to be able to participate at the OHT. I think that that's part of the challenge in a lot of places is there might be interest, but how do I get there and how are we organized collectively to be able to talk together in one voice? So we've just highlighted a few examples where we're always interested in capturing more and understanding what those sort of special ingredients are for success so that we can champion them and share them across the region. So those are the ends of our slides. I'm not sure if we wanted to talk questions now or proceed through the agenda.
I think Allison, again, thank you, Allison and Phil, for presenting that from the Ministry of Health. I think maybe we could answer some questions towards the end, or perhaps maybe even type some of the answers if we can in the Q&A. That'd be great, just to make sure that we try to stay on time. So thank you again, guys. Next, I'd like to introduce Dr. Jim Wright. Most recently, he was professor of orthopedic surgery at the University of Oxford in the United Kingdom. Previously, he was chief of perioperative services and surgeon-in-chief, Department of Surgery, and vice president at Sick Kids. And he's also been awarded the Order of Canada. Currently, Jim is the OMA Chief Economics Policy and Research. So thank you, Jim, for presenting today.
Jim, we meet every week or every other week. And much of what you're going to hear about OHTs, I would say, is aspirational. And this is a work in progress when we recognize that OHTs were introduced just over 1 year ago. So we've come a long way. You heard about the quadruple aim, and I just want to point out a couple of things. One, this idea of population health. So it's not just a focus on patients, but it's in fact the entire population health. So that's an important difference. Also this idea of provider experience. So that moved it from the triple aim to the quadruple aim. As we begin to struggle with physician and clinician burnout, we have to understand as we proceed with OHTs what that effect is. And I would say that you're going to hear slightly different views about the timeline. I think probably it's 3 to 5 years, and it may even be 10 years before we realize the vision of all of the sectors coming together for a capitated population, the entire continuum of care, and setting up the governance structures. The OMA is very focused on integration. So that's what we're hoping to achieve with OHTs, but constantly people would want to understand, why would a physician want to participate in an OHT? And we would suggest that physicians, patients, and the OMA have long advocated for integrated care. And if we're able to achieve this, integration would allow physicians to focus on what they do best, caring for patients. I hear constantly, particularly from primary care physicians, they spend a huge amount of their time coordinating care, chasing down information, a lot of administrative work, and less time doing what they really want to do, which is looking after patients. So if we achieve this integration, that would be a huge success for everyone. And I don't mean to say that we are discouraging of OHTs, but our focus is on integration, and we quite excitedly believe that OHTs is the way to achieve it, but what we're really trying to achieve is integration. Our position, and this is based on evidence from other jurisdictions, particularly in the US, but also integrated care teams in the UK. For physicians, they must be voluntary, physician-led, and primary care based. These are the factors that seem to lead to the best quality at the lowest cost. So we believe that physicians are a key stakeholder. They know what's needed, and they are perhaps in an ideal position to know how healthcare should be organized and delivered. As I said on the previous slide, that physician-led integrated care organizations in the US, which are called accountable care organizations, have achieved the best results with the lowest cost. And it's vital that physicians are engaged and buy into the change as we move forward. So government is acting for active participation of physicians, but I think it's important for you to recognize not all of you who are on this call will have the same level of involvement. But we think it's vital that physicians come together to form local physician associations, such as your primary care network, so you can have a voice in how care is redesigned. And we would suggest the best way to achieve that is to unite and form local physician associations. But we strongly recommend you move beyond just focusing on primary care physicians, because we think it's important that community-based specialists and hospital-based specialists come together. So all of those physician voices can be heard and represented at the table. And ultimately, physicians will, and other clinicians will be part of the governance of an OHT, part of an OHT governance board. It's also been suggested that we've learned a lot from COVID. So many of the burgeoning, beginning OHTs, it turned to be a very effective organization for physicians to come together, to integrate with other care providers and deal with COVID-related issues. So this further emphasizes to us that while we strongly believe in physician organizations are important in supporting OHTs, they're also incredibly useful in dealing other stresses within the community, and COVID is a perfect example of something that came completely unexpected, and in those regions with physician organizations, how powerful it was. So I'm going to end here by saying that the OMA is here to support physicians. We recognize that some of you will be leading, many of you will be interested, some of you will be not so interested, a segment of you will be unaware, and we anticipate some of you will be refusers. And all of the concerns that you can raise, perhaps your concern about all previous efforts, are legitimate. I would only tell you I've been in practice for 30 years. I've never seen this level of excitement. I've never seen this level of change in only a one-year time frame. So I'm incredibly excited. We have to recognize there are a lot of barriers. Time and lack of funding is something that we're very conscious of, and we continue to advocate for, particularly as we move into governance of OHTs. There'll need to be some kind of model that compensates people for their time. We have an OHT website with the OMA, and I encourage you to have a look through that. We have a lot of supports. We're working to develop appropriate measures. We have a legal and governance support. If you want to understand contracts and arrangements and how to organize yourself, OMA Legal is very helpful. Nicole's on the call tonight. The regional managers are a key part of how the OMA can support you. We participate in webinars, and we participate in a lot of meetings, and we continue to advocate for funding. So what are we hoping to achieve? Well, physician champions, physician associations, influencing, and I'll continue to harp on this OHT funding for physicians. So I think I'll stop there, and happy to take questions when we get to that part of the meeting.
Really appreciate it, James. Thank you again for presenting the OMA perspective. So next, we have 3 of our local OHTs trying to answer those pointed 5 questions. We only gave them a minute each for each answer, but we'll extend it by a few seconds here and there. So first, we're going to introduce James Pencharz from our Mississauga OHT. He practices comprehensive family medicine with the Credit Valley Family Health Team, and he has a special focus of homebound elderly and patients with palliative care needs. He's an active teacher within THP at Credit Valley Hospital Family Medicine Residency Program and teaches undergrad students as well. He's the board chair of the Credit Valley Family Health Team and member of the OHT Interim Governing Council. So thank you, James, for presenting today.
Thanks so much, Sahal. Thank you very much for having me, and thank you for organizing this session. It's very exciting to be here and be able to present on behalf of the Mississauga, Ontario Health Team, particularly the primary care members. Next slide, please. So why integration? I think Jim has done a really nice job of articulating this, but I'm going to briefly go through it. It's very clear the system is fragmented. I think any of us who practice family medicine or in the primary care system throughout the province, particularly in Mississauga, feel that acutely. From a provider's experience, we feel tired, we feel disconnected from others within the system. We don't feel as though we're part of a group of physicians working together towards a common goal, and the OHT vision would work towards supporting that. From a patient care experience, the people that we care for experience long wait times, they feel inconsistency of care, and there's challenges with regards to resource inequity. Physicians who practice in different models have access to different levels of support with regards to professional care teams. and the team-based model that I think all of us deserve and should be allowed to have access to for our patients. And so the integration journey that we're talking about with regards to OHT will attempt to begin to address that. And as Jim articulated, the COVID-19 pandemic has really amplified all of these challenges. Next slide, please. So the original vision of the Mississauga OHT is to bring together our vision to improve the health of people in our community, that being Mississauga, and the experience of our providers by creating an interconnected system of care across the continuum from prenatal care to birth to end of life. Next slide, please. So I'm just going to personalize a little bit. Why do I believe with regards to the Mississauga OHT? And I'll start first just by articulating that I do practice within a fit-FO model. So I do have access to interprofessional care team members, and I do have the benefit of the FO capitated model. The pillars of the Mississauga OHT and all the OHTs are primary care, acute care, and home care. So I think it's really important, as Jim and others have articulated already, that this basis and importance of primary care is central to the success of OHTs. And so if we can think about that from a perspective of practicing family physicians, as we've been talking about for years, I've been in practice for coming up on 11 years now, of having a voice within the system, this is a significant opportunity to be able to be a voice and to be able to lead this change. There is within the Mississauga OHT equal representation at the table, and it's a journey that we believe, those of us who have started along the primary care journey with regards to Mississauga OHT, a journey to be taken together, and together means all of the family physicians practicing within Mississauga, and I certainly do take Jim's point agreeably in terms of needing to create that sense of community with specialist colleagues as well, whether they be community-based or hospital-based. Of note, within the actual interim governing council for the Mississauga OHT, there are 4 primary care chairs at the moment. I occupy one of them temporarily for the first year, and obviously as the boards constitute and construct themselves, other members, hopefully of other family physicians in the community, will come in to occupy those positions. The other reasons I believe in the Mississauga OHT is the improved recognition of the value that primary care brings to the system, improved access to team-based care. Specifically, our family health team has launched a new professional care team model, providing access to social work, dietitians, nurse practitioners, nurses, and social workers into the community of Northwest Mississauga to provide support for the patients who receive care there. It's in order to improve access to expedited investigations and specialists, through the example that Phil Graham gave of care pathways, where it's a standardized method of care where patients will get access to care as best practice. And again, because of the COVID-19 pandemic and the challenges we faced, integration will help to support that. Next slide, please. So as we've been recalibrating within Mississauga, as Allison Costello referred to, we were asked in March to put a hold on active planning with regards to Mississauga OHT. But we've been meeting informally to talk about how we can support our community. And so our focus at the moment is how to support our community and our community providers as we prepare for Wave 2. Next slide, please. To date, primary care engagement to date, which has mostly been within the application and the early stages of year 1, has been engagement to 95 primary care providers within Mississauga. The full application was supported through weekly calls to primary care leaders within the former Mississauga Halton Lynn. And more than 20 physicians actually read our full application and provided written feedback to the application. We have 7 physician groups, including the 3 founding primary care teams, so the Carterville Family Health Team, Somerville Family Health Team, and CarePoint Health, as well as 4 other physician groups, and 16 additional collaborating physicians and physician groups. So we've got the ball rolling in terms of primary care engagement. And as I articulated, the governance structure calls for 4 seats on the interim governing council that are occupied by primary care only. Next slide, please. However, our primary care engagement is not sufficient. And I think an opportunity like tonight to be able to reach an audience across Mississauga, to be able to articulate the importance of coming together as a community, the importance of coming together as a physician group, to be able to provide input and to be able to provide leadership at the highest level, whether it be developing the care pathways, whether it be at the interim governing council, is a unique opportunity for us. We require broader representation in terms of fee-for-service, physicians who practice in FIG models, physicians who practice in blended models. We need that voice. We need to understand how the OHT can best serve those models and how we can best serve physicians in those models. There's a desire for ongoing continuous engagement throughout this journey. And as we've been on hold since March, we're hoping to restart, as Allison and Phil have articulated. And our hope is to build a sense of connection within the system so that family physicians feel connected as a primary care system together along with our Mississauga OHT. Next slide. From my perspective and the perspective of the primary care leaders within the beginning of the Mississauga OHT, we understand that physicians know and understand the system. We understand that local solutions are the most effective, that there is an issue with regards to equity around access to services across the Mississauga area, and that the principle of the OHT really needs to be to make our life simpler and easier within our caring of our patients. Next slide, please. So just briefly, some ways that we've begun to brainstorm about how we can support the system together as we think about wave 2 is, can we make use of the hospital resources with regards to PPE procurement? It's been a significant challenge for all of us in wave 1, and the hospital has begun to explore how they can provide support for primary care with regards to PPE procurement. How can we support each of the family physician's office with regards to best practices for infection prevention and control implementation? As some of you will be aware, within Mississauga, there was a successful family physician-led peer-to-peer IPAC extender program that went into long-term care homes and was able to support long-term care homes during their most challenging phases. As we think about phase 2 with regards to COVID, is there an opportunity there to be able to use a similar model to support each other as we continue to open up into more in-person care? How do we provide connection to a network of other primary care providers? How do we work together and facilitate communication without having too many cooks in the kitchen? And then finally, the issue around assessment centers within Mississauga has been a significant challenge within primary care. And how can we work together to improve access to assessment centers? And how can we build either symptomatic centers or influenza-like illness centers that will be able to provide safe centers for patients who need to be seen in person when challenges around PPE continue to be present. Next slide, please. We are looking at a few different models to be able to engage with our system now that we're starting to get the go-ahead from the ministry. Similar to the current webinar, we're looking to develop virtual meetings where we'll explore what role the primary care physicians practicing in Mississauga would like to see Mississauga OHT play. Can we play a role with regards to PPE? Can we play a role with regards to IPAC? Can we play a role with regards to advocating improvements in assessment center or ILI centers? And how can we facilitate communication without being another voice and confusing things further for physicians? Once we've collated that information, we solicit feedback through survey methods and then come together again for a co-design session where we can settle on a final stage of planning and implementation for the fall 2020. Next slide. So just some questions to leave with the group. From your perspective, how big are the challenges that you as a physician right now are facing with regards to optimization in in-person care? And how do you think that we within the Mississauga OHT can help? And how can we work together to build that system? How would you as a physician practicing in Mississauga like to connect to others within the network of providers? And I think that PCN has taken the leadership role in this particular scenario, but we would like to continue to collaborate with all practicing physicians and the PCN in this endeavor. And last slide, please. Just wanted to provide you my contact information. Really keen to connect with anyone who's interested or wants to know more about the approach we've taken so far. It's backed up by a lot of work that's been done, obviously, with regards to the application in the early stages. There's our webpage for the Mississauga OHT. And I just want to make a small plug for the Credit Valley Family Health Team Interprofessional Care Team expansion. If you have patients who you think would benefit from access to services, social work, dietitians, nurse practitioner, registered nurses, please look at the links below that you'll have access to be able to make referrals to our programs. Look forward to hearing from you. Thanks, Sahal.
Thanks, James. I was going to cut you off earlier, but I'll let you talk for a couple extra minutes. So thank you for presenting the Mississauga point of view for the OHT. Next, I'd like to move to Arieg Badawi, who's going to talk about the North Halton OHT. Arieg is a family physician at Kelso Lake Medical Center in Milton. She completed her family medicine residency and fellowship in low-risk obstetrics at the University of Toronto. She has an MBA from Rotman School of Management, and she's currently leading the North Halton, Ontario Health Team. And it's a primary care-led OHT, so it's quite unique. And it aspires to achieve precision patient-centered care. Sorry about the tongue twister there, Arieg. Thank you for presenting.
Thank you, Sahal. So hello, everyone, and thank you for joining us. So I'm going to talk about the North Halton OHT. Next slide, please. So geographically, we are Acton, Milton, and part of Georgetown. And it's very unique because you can see that we are surrounded by 4 OHTs, and we're learning a lot from all of the OHTs that are around us. We are primary care led. We view ourselves as a value chain integrator, and I'm going to talk about this later. And our philosophy is the quadruple aim. So it aligns with the strategic goals of the Ministry of Health. Next slide, please. Vertical integration, the Ministry of Health. Underneath that comes Ontario Health. Our governing body sits under Ontario Health. The physicians within the governing body have a cumulative of 100 years of experience altogether when it comes to primary care, leadership. They also bring business backgrounds and health policy. Our horizontal integration comes at the inter-practice units, which is the IPU. And here I'm going to talk about a value chain integrator versus a value chain partner. So value chain partners is when primary care has a seat at the table, but the table is led by other groups. When you're a value chain integrator, you're the person, the table is yours, and you invite other people to have seats within your table. And so that is the difference, and that's the uniqueness of having a primary care-led OHT. For example, when you look at the mental health IPU, within the mental health IPU will sit all of the mental health organizations that are providing care for our patients. The director of the mental health IPU will have a seat on the governing table. This will give us a unique ability to be able to choose partnerships, have control over contracts. When we're talking about key performance indicators and accountability, we need to make sure that we have control over who we choose to partner with, because we're going to be accountable later on for value-based care and the cost of that care, in addition to the return of investment that's included within that care package to the Ministry of Health. For example, when you look at the elderly care IPU, we are choosing to partner with a company. We looked at their financial records, we looked at their history. They have this long-term care ability they have long-term care facilities, retirement care, and home care. And so when you're a value chain integrator, you get to step back and see your patient journey from when they leave the hospital all the way to long-term care. And then you can see areas where you feel, okay, here I need to kind of improve certain things with key performance indicators or funding, which gives us a unique ability. We are frustrated as primary care. The system falls down. We are the ones that kind of carry the system. So we are in a good position to be able to design a system that works for our patients and also allows us not to kind of burn out. Next slide, please. And so what's in it for you as a primary care physician? I think the first thing would be being part of a team is very, very important, so you're not alone. Lessons learned from COVID for us. So when COVID hit, it was overwhelming. We had 2 communication platforms already set up. So our Chief Information Officer, Greg, has our North Halton OHT website. You can go in. It talks about our vision, our mission, who we are, what is our brand, why are we there, and why are we forming this OHT together. Dr. Latif had formed a WhatsApp group, which was basically last June, for us to communicate when we started to kind of come together with regards to this North Halton OHT. What it did was it became a communication platform where our anxieties, like there was, you needed proper information coming down. We needed real-time information to be able to help our patients, but also supporting our colleagues. It was an overwhelming time, and you knew you weren't alone. So if you had questions about, okay, I have a patient who has pneumonia-like symptoms, what do I do? And so that was like a very important place where we can share anxieties. Dr. Malik was always updating us with the criterias, like from the assessment center. Sometimes within 24 hours, the criterias were changing. So things were happening very quickly, and we were able to keep on top of things. And at the same time, we were able to support each other. With regards to PPE, so on the 23rd of March, which is a week after the province was basically locked down, we came together in the governing body and we were saying, okay, we have issues with PPE shortage. So Dr. Alam went ahead and she was doing community drives. Some of us got together and said, okay, there's a problem with demand and supply. And so there's a lot of demand, very little supply. We need to do something. So we were able to basically build a supply chain. We formed a group purchasing organization. We leveraged a charity, which is Penny Appeal, and we were able to have our supplies there by the 4th of April, which was 3 weeks later. And the story still in the environment was there was a shortage of PPE. So the uniqueness of having a small group like ours, or it's not a small group as we expand, but we have a startup feel, which means we're very agile and we can basically pivot very quickly, and we're primary care attuned. So having said that, we were able to support community physician specialists who needed PPE. We were able to help other primary care docs within Ontario who reached out, and also like shelters, women's shelters who needed PPE. And so that happened because we were not waiting for a top-down approach. We were basically making decisions. And when things are changing very fast, and that's the healthcare environment we're in right now, you have to have the autonomy to make decisions very quickly. You cannot wait for things to come trickling down for you in order for you to respond. With regards to phase 2, I would say you need to be, first of all, you need to be part of a team. When you're part of a team, you're connected to the matrix. You're not alone. And so you will get support, even if it's in the form of information. The primary care network is a very good place because for me, they're like Switzerland. So even if you don't want to be part of any OHT, you're not sure yet, they're Switzerland. You can basically join them and basically, voice your concerns in a way. For phase 2, the forecast does not look good. Anyone with a little bit of intellect, you can look at south of the border, Australia right now. We are going to need to respond appropriately. And I'm not going to respond just because of our governing team. We need to have a meeting, and we do Zoom meetings before the OHT, where we need to come together as a group and figure out, okay, how are we going to respond to the second wave that's going to hit us? Are we going to be sending things to the emergency room? Are we going to have walk-in clinics that are basically going to be set up just for patients who are ill? But also, what does that mean for the patient that's coming to seek care from your clinic? And so we're still working with that. Hopefully we'll be able to come up with something within a couple of weeks. And my advice, just before I kind of sign out, is this is exciting. Primary care is the strength of the healthcare system. We saw this right now with the COVID. When COVID hit, the focus in the beginning was where the hospitals were, which was rightfully so. We needed ICU beds. We needed to make sure the emergency room was empty. The neglected areas in our healthcare system, long-term care, took the hit. But then people are not thinking about, okay, how come the emergency room was not overwhelmed? It's because you showed up. I'm a fee-for-service doc, and even though I had to let go of half of our staff in our clinic, you guys showed up. So I'd like to say thank you. And you need to kind of have that confidence with regards to who you are as a primary care doc and how important you are for the system. Because if we go away or we shut down, the system shuts down. So thank you.
Thank you, Arieg. Very well said. Thank you. Next, I'd like to introduce Dr. Kristianna Martiniuk, who is going to talk about connected care, the OHT in Oakville. It's also called the Halton OHT. Dr. Martiniuk, or Chris, graduated from the University of Toronto and went to McMaster for her residency, and currently she's a professor, adjunct associate professor, teaching family medicine residents and medical students in Oakville. And she's been a family physician for 25 years in Oakville, and she was also the former PCN co-chair until December 2019. So thank you, Chris, for talking to us today.
Thank you, Sohal. I think you've covered my first slide, so we'll move right on. We're getting to the end of the night. Thank you for inviting me and to the PCN, as well as everyone for joining us tonight. And I won't go into detail on my slides. A lot of the information was covered by the previous speakers, which was all very well said. So our first year priorities were to involve the communities of Halton Hills and Milton and Oakville, with a first year focus on mental health, palliative care, home and community care, as well as digital health. The priorities were to be collaborated on by primary care, public health, home care, palliative care, as well as the acute care system within Halton Healthcare Services. The OHTs, as you've heard, have been asked to put their pre-COVID work on hold, but there has been a lot of activity, of course, with the COVID priorities. And the partnerships that were formed just in their infancy, really, within the last year have been key to navigating this pandemic to date. Next slide. The key principles that I think there's a great overlap within different OHTs, but I think we need to focus on value for primary care, bringing a meaningful agenda, and that has to be set with primary care. We need to have inclusive representation regarding geography and including funding models. There needs to be effective communication. There's been communication from Halton Healthcare and the Lynn and Halton region, but it has been spotty over time. To communicate with primary care, by primary care, has been lacking. There's been a WhatsApp group formed within our region that's been helpful. There's needs to be a balance between physician independence and autonomy and the system interdependence that we all work within. And we need to develop that integration and make it a strong foundation of the teams. There needs to be impact, which has to be effective and timely rather than bureaucratic to engage primary care. And relationship building is key. Already there's been a new association of family physicians forming in Halton, again in its infancy. And we are starting to integrate specialists, but this will be important going forward. Next slide, please. How will the OHTs change a physician's life? I think this remains to be seen, but I think essentially because of that paradigm shift that the OHTs have a mandate to include primary care. As long as I've been practicing, I've never seen such a mandate, and I think that is key. And of course, participation is voluntary. The opportunity is ours to get involved and shape the OHTs. You can see from Dr. Pencharz and Dr. Badawi's discussion how their OHTs are shaping to have local flavor based on what local physicians feel is important and what's going on the ground. So how do we want them to change our lives, I think is the question. So far there's been communication and work around PPE procurement. Campaigns have provided and distributed donated supplies. There's been rapid information sharing just during this pandemic. Partnerships have been strengthened, and there's an ongoing effort to work with our hospital and other partners in our area for an effort to procure PPE. There's ongoing work in terms of what are the assessment centers going to look like and how are primary care physicians going to take a role in this, particularly with Wave 2, and as we see that there are clinical presentations that overlap with what we see every day in family practice, and how are we going to manage this. One very specific example that our team has worked together to help primary care was with the diagnostic imaging ramp up that occurred over the last several weeks in our community. And initially there was a bit of a dump where faxes were sent on over the course of a couple days to our offices to rebook all of the mammograms that were required to be rescheduled for our patients. And by working with our hospital partner, I was able to have that change so that the DI department would book those rescheduled mammograms. And I found that type of communication prior to the OHTs really wasn't set up. So those communication channels, although they're new, they're actually very effective. Of course, the OMA remains the negotiator regarding physician payments as well as models, and that does not show sign of changing, but the OHT primary care representatives are advocating strongly for stipends for work done on behalf of the OHT, as well as equal representation of physicians in both the fee-for-service models and the capitated models within the OHTs. Next slide. And finally, there's already work that's been ongoing many Zoom meetings involving many primary care physicians along with our partners for PPE, group purchasing, organizational structures to be looked at, IPAC outreach to physician offices, modeling the healthcare sector reopening, what that's going to mean for primary care, how we can help and how it will impact us. Assessment centers have involved all partners within the OHT in Halton, and we meet regularly also with Central Region OHT leads several times a week so that we're not working just locally, but also within a larger region. And I think my email got cut off this slide, but other priorities as seen by primary care, I think needs to be brought forward. This is for primary care to become involved in. My email I'll forward for later as well, but it's KLC Martiniuk, MARTINIUK @gmail.com. Thank you.
Thank you, Chris, for presenting that. I know we're at 9 guys, but if it's okay, we'll try to maybe take 10 minutes to just answer some of there's some common themes within the questions. I don't think everyone can see the questions. I know all the panelists can. So again, thank you to everyone for coming out tonight, and thanks to all the panelists and all the speakers. But we just wanted to ask some basic questions, right? Because there's a lot of anxiety as soon as we're talking about system transformation. Anytime there's a change in any system, there's a lot of anxieties associated with it. And we're talking about individual physician offices, as well as group practices that could be affected by, well, will be affected by everything as we move to this integrated model and team-based approach. So, you know, a few of the questions have focused on fiscal accountability and what exactly that means. And, you know, maybe Phil or Allison could answer that question. And, you know, who will be penalized, or, you know, if you're not making certain accountabilities, what's going to happen in those cases? And it might be a bit early for these questions, but if you could maybe talk a little bit about that, guys.
Yeah, I can maybe start that off. Thank you for the question. And the question of fiscal accountability is a question that we receive quite frequently, and I think that's understandable. You know, maybe just start off by reiterating Dr. Wright's comments in his presentation about this being quite a bit of a long game. So we're not looking at a state of OHT maturity across the province in a matter of 1 or 2 years. And with credit to the government of the day, they've seen that as well. Typically initiatives kind of follow the electoral cycle, but I think and we have recognized that, you know, based on international experience, this is change that is not affected, that does not happen in a couple of years. So when we do talk about fiscal accountability, we are looking at a sort of mature state. And it really is trying to rectify what is a perpetual challenge in our healthcare system today, which is the siloed nature in which services are funded. And the challenge that brings in terms of accountability for a population. Certainly you have, you know, good lines of funding and accountability for particular types of hospital services, for, you know, home care services, for mental health and addictions, for palliative care. And one of the challenges associated with, not the only challenge, but one of the challenges associated with having a more integrated system of care is that incentives are misaligned, accountabilities are misaligned, funding levels and funding mechanisms are misaligned. And so how can we expect a system at the frontline care level to deliver services in a more integrated manner, where at the back office, at the ministry and some of our partners, we're not enabling that care to be integrated by you know, sticking to our fairly rigid silos. So fiscal accountability in an OHT context really means empowering local providers, leaders, to actually have a fiduciary responsibility over an integrated fiscal envelope to support the care for a defined population. as you know, because right now accountability, you know, is fractured, and when multiple people are accountable, what really that means is no one's accountable. And having that accountability as close to the patient and as close to the community as possible, we think optimizes the chances of actually having the real change be experienced by the patient and the community level. And, you know, clinical accountability plays a large role in that in terms of designing care in a way that's integrated, but there's a fiscal and a fiduciary accountability piece that is part of the puzzle also.
Jim?
Add to that, so Hal?
Yeah, please.
There's two elements. One is fiscal, and I won't go into the details, but developing a funding envelope that accurately reflects the expenses associated with the full continuum of care is a mammoth undertaking, and that's why I put the horizon 3, 5, and maybe 10 years away. The second is accountability. So whenever you talk about accountability, you have to talk about to whom, for what. So that's a frightening conversation. Am I going to be accountable if the hospital doesn't deal with its readmissions as a primary care doctor? I would shift the conversation from, I'm not saying that these are not aspirational aims and they aren't things that we have to get to at some stage. The reason to become involved in this is because integration. Focus on bringing those care delivery to the best advantage of your patients. That should be the reason why you're getting involved. And anything that involves fiscal and accountability would have to be negotiated. And that's where the OMA and a whole negotiating arm may come to support you. So the focus should not be on the fear related to fiscal accountability. We know that someday that's going to be where we end up. But for the time being, focus on integration, bringing those services together and allowing you to do what is best for your patients. So I'd shift the conversation.
Thank you, Jim, for saying that actually and clarifying that. And thank you, Phil, for answering the question. You know, a few of the questions have also been around, is it mandatory? When is it going to be compulsory to join? And I think we've addressed that briefly, but if somebody could state that again on the team here in terms of when it's going to be compulsory or if it's going to be compulsory.
I'll start off. I would just simply say, if we do our job properly, we won't have to go there. I think to Dr. Wright's point, you know, we want to be positioning and sharing early successes so that particularly primary care physicians, but all physicians and providers see the inherent value in the model, so that we don't actually have to even consider a mandatory or compulsory participation. My view would be that, you know, partnerships that are forced are not going to be set up for success. And so our approach to date and the approach that we'll be taking in the near future is to continue to build coalitions of the willing to demonstrate the value of the model so that clinicians and other providers want to participate. And I think I'll leave it there.
Thank you. And then there's a question around you know, IT actually as well. When all of us have kind of our unique electronic medical records, you know, how are we going to connect with each other? Are there plans for a united electronic medical record around an entire OHT or in the province for that matter?
Phil, do you want me to take that one?
Yeah, go nuts, Dr. Wright. Thank you.
I don't need the formal title, Phil, but thank you. Phil and I are going to be bringing many of the players together, including the digital, and the ministry has a digital playbook that's supposed to help you. But I would say the direction, rather than a single EMR, is to work on something called APIs, which allow the various digital components to talk to each other, and that the essential information moves between. And the government has introduced regulations just about 3 or 4 weeks ago that would hopefully lead us to a place where the digital assets, not just the EMRs, the hospital information systems, your e-consults, everything, they need to talk to each other So this is recognized as a top priority. Clearly, you've been waiting this for a long time, but again, I see advancement on this goal in a way that I've never seen in the past. So Phil, if you want to add to that.
What he said. Nothing. I think that accurately captures it. Thank you, Jim.
That's great. And then there's been a number of questions around physician funding, when it comes to this. And here we have both the OMA and the Ministry of Health in the room together, which is great. Which, as the average family doctor practicing, you don't get to attend things where you get to see both parties in the same room together. So if you guys could comment a little bit on how this model will perhaps change physician funding in the future, and everyone's worried in terms of their initial impact of their individual practices and their individual businesses.
Well, I think I can maybe start off. That is a topic for bilateral negotiations between the parties in terms of core physician funding. I can't speak to that in terms of any detail, and I think there's value in letting that process play out, and I'm sure there'll be opportunities for feedback and to feed into that process. We do recognize at another level that from OHTs we have heard the need for implementation funding, for lack of a better term. I think as it's been explained to me a couple of times to date, the OHT initiative has been fueled primarily by goodwill of leaders and participants, and that tank is running out to some extent. And so I think we at the ministry recognize that OHTs may need some implementation support to keep the momentum going, to bring people together, to support some early patient-facing improvements where the plans have materialized or come that far. And that's something that we're actively considering just to help keep that momentum going. So on that piece I can speak to, but on the physician funding in particular, there's a process for that to be negotiated. I'm not sure if Jim has anything else to add.
Yeah, just to work backwards to emphasize Phil's point, there may need to be some, I'm inspired by the work that you all have done, working off the side of your desks, volunteering on something which is done for the, what I admire, which is doing what's best for the system and done best for your patients. But to continue to develop OHTs, at some point, I believe we're going to have to recognize that this is an effort for physicians and all players, and they need to be appropriately compensated. Clearly, when we get to the point where physicians are leaders within OHTs, there's going to have to be a recognition of that time spent. And on the issue of physician compensation for their clinical activity, that would be the basis of negotiation through the physician services agreement. And at this point, there's no plan to enter into any negotiation on physician compensation as it relates to OHTs. Time will tell, but I don't anticipate in this round we'll be in a position to do that. So we're talking probably another 4 years before it even becomes a reasonable topic of conversation. Even then, my suspicion is that physician compensation will be outside of OHTs.
Again, thank you. I think we should call it a night there, guys. I want to thank each one of you. So I want to thank Allison, Phil, Jim, James, Arieg, and Kristianna for agreeing to put this together. There was a wealth of information, I think, for all of us. It was really, really helpful. I want to, of course, thank Nicole at the OMA for helping with everything in terms of the webinar itself. I want to thank the entire board, and a special thanks to Jennifer Tran, who's our senior advisor. She's in terms of primary care engagement and health system planning, and she's supported by the LIN. So again, thank you everyone for coming out. I also want to say that, in mid-September, we're planning to hold our next primary care network Mississauga Halton event. Would love it if you guys can attend again, and we'll send out the invite at that time. So it's September the 15th is our tentative date right now. Again, thank you everyone for coming out and making it a successful event. Take care, everyone.
Thanks, Sohal. Have a good night.
Thank you very
Thank you,
much.
guys.
Thanks, everyone.